Allergic disorders, urticaria and angioedema. Urticaria, common disorder characterized by elevated edematous lesions, variable in size from few millimeters to several centimeters, involving any area of skin, mucous membranes. They are localized or generalized, transient, lasting only for a few hours. Angioedema occurring where vasodilatation involves larger sized blood vessels of deep derms and hypoderms, occurring in soft tissues as lips, eyelids, genitals, and may involve the larynx, leading to laryngeal edema and respiratory obstruction necessitating emergency intervention. Types: allergic type, manifestation of type 1 hypersensitivity. Mast cell is the primary effector cell in urticaria reactions on first exposure to the antigen. Specific IgE antibodies are formed. They bind to IgE receptors on mast cells. On subsequent exposure, antigen-antibody reaction occurs on the surface of mast cells, degranulation and release of mediators, including histamine, prostaglandins, and leukotrienes. Causes: exogenous and endogenous. Exogenous: ingestants, injectants, inhalants, and insect bites. Endogenous causes: microbial infections, bacterial, viral, fungal, intestinal parasites, protozoal and helminthic manifestations. Medical disorders: SLE, liver diseases, malaria, thyrotoxicosis, internal malignancies, lymphoma, and GIT cancer. Pregnancy. Autoimmune etiology is suspected in some cases of chronic urticaria, autoantibodies against receptors on mast cells. Non-allergic type: physical urticaria, cholinergic urticaria. Physical urticaria: wheals appear at sites of exposure to physical agents such as sun, heat, cold, water, pressure. Cholinergic urticaria: patient feels a pricky, itchy sensation immediately following physical effort, psychological stress, or increased environmental temperature. Small wheals, 1 to 3 millimeters, may be observed. Lesions subside usually within 1 hour. Secreted acetylcholine stimulates mast cells to release histamine. Papular urticaria: special variant of urticaria, including type 1 hypersensitivity resulting in a wheal, type 4 resulting in lymphocytic cellular infiltration and papule formation. It occurs in response to insect bites, affecting infants, children, and adolescents. A wheal appears at the site of the bite within 1 or 2 days. Itchy erythematous papule appears at the center of wheal and stays for a few days. Treatment of urticaria: avoid precipitating factors, antihistamines, mainstay of treatment. Systemic steroids can be used for short-term management. Epinephrine, adrenaline, 300 to 500 subcutaneously or intramuscular in cases of anaphylaxis or angioedema of the oropharynx. Cyclosporin, biologics, anti-IgE. Drug eruptions: adverse cutaneous drug reactions manifest in several forms, some of which may mimic any skin disease, but they differ by having acute onset, atypical distribution, more inflammation, and they subside after stoppage of the causative drug. Other cutaneous drug reactions are unique and include fixed drug eruption and toxic epidermal necrolysis. Then we have exanthematous reactions. 2. Drug-induced urticaria and angioedema. 3. Acneiform eruptions. 4. Fixed drug eruption. Exanthematous reactions characterized by papules upon erythematous background. They occur within the first 2 weeks after treatment and even 10 days after discontinuation of the causative drug. Rash starts proximally and generalizes within 1 to 2 days. Pruritus distinguishes drug-induced exanthes from viral exanthes. Common causative drugs include penicillin, trimethoprim sulfamethoxazole. Drug-induced urticaria and angioedema occurs by immunologic or non-immunological mechanisms, manifests clinically by wheal, subcutaneous edema, angioedema, and or more severe anaphylactic reactions with bronchospasm, laryngospasm, hypotension. Common causative drugs include aspirin, NSAIDs, penicillins, ACE inhibitors, and blood products. Acneiform eruptions characterized by papules and pustules resembling acne, and they occur in acne-prone sites. Absence of comedones differentiates them from acne. Common causative drugs include corticosteroids, antiepileptic drugs, iodides, and bromides. Fixed drug eruption characterized by red to violaceous macule or patch, which may develop a central blister that may erode, involving skin and or mucous membranes. Common sites are lips and genitalia. They are named fixed because they are fixed to site and fixed to drug-related compounds. Common causative drugs include NSAIDs, paracetamol, sulfonamides, tetracyclines. Management: Identification and discontinuation of the cost of drug. Local, corticosteroids, creams or lotions for exanthematous and fixed drug eruption. Drying antiseptic solutions as potassium permanganate for blisters and erosions. Soothing lotions as calamine lotion for exanthematous and urticaria reactions. Systemic antihistamines for exanthematous, urticarial, and fixed drug reactions. Corticosteroids for severe and generalized reaction except for acneiform eruptions. Melanocyte disorders. Vitiligo, common, non-infectious, genetically determined disorder characterized by loss of melanocytes. Primary lesion, well-circumscribed milky white macule or patch, affecting any part of the skin or scalp, possibly leading to whitening of hairs. Pathogenesis, melanocytes are destroyed and disappear from epidermis. No melanin is produced, leading to appearance of the disease. Etiology, autoimmune, neurogenic, contact or chemical theory, oxidant-antioxidant imbalance. And autoimmune theory, anti-melanocyte autoantibodies and cytotoxic T cells cause destruction of melanocytes. This theory is proved by association of vitiligo with autoimmune diseases such as pernicious anemia, autoimmune thyroiditis, diabetes. Precipitating factors include psychological or mechanical trauma. Neurogenic theory, melanocytotoxic substance released from nerve endings cause destruction of melanocytes. Contact or chemical theory, melanocytotoxic substance, phenolic derivatives in gloves, slippers, and film developers cause disease in specially predisposed persons. Oxidant-antioxidant imbalance, increase in reactive oxygen species. Clinical types: localized, including segmental vitiligo, generalized, universal, acrofacial. Differential diagnosis: tinea versicolor, post-inflammatory hypopigmentation, and pityriasis alba. And then we have treatment. Phototherapy, photochemotherapy stimulates residual melanocytes in hair follicles for repigmentation. POVA, UVB, targeted and narrowband. POVA, oral administration or topical application of cerulean with silent P plus ultraviolet light type A. Narrowband ultraviolet type B, 311 nanometers. Targeted ultraviolet B rays, 308 nanometers. Medical treatment, steroids, topical and systemic. Antioxidants, topical immunomodulators. Surgical treatment, punch grafting from normal to diseased site, tissue culture and grafting of melanocytes, camouflage, skin-colored materials to hide the affected areas. In cases of universal vitiligo, residual pigmentation of normal color may be removed by phenolic compounds, hydroquinone, and laser. Hair disorders, alopecia, hair loss. Normal hair cycle. Normally, each human hair follicle shows intermittent activity. Scalp hair grows for a period of 3 to 8 years, anagen phase, which differs amongst individuals. Then follicle growth stops for intermediate period of 3 weeks, catagen phase, and then followed by resting period of 3 months, telogen phase, at the end of which hair is shed and new hair starts to grow in the follicle. At any given time, scalp shows average of 85% of hairs in anagen phase, 5% in catagen phase, and 10% in telogen phase. Every day, about 50 to 100 telogen hairs are shed and replaced by newly growing hairs. Types of alopecia: cicatricial scarring alopecia and non-cicatricial alopecia. Cicatricial alopecia, hair follicles are destroyed, leading to scar formation and permanent hair loss. Causes: mechanical trauma, burns, fungal infections as Carian and Favus, viral infections as herpes zoster, collagen diseases as discoid lupus erythematosus, inflammatory diseases as lichen planus, neoplasms as basal cell carcinoma. And then we have the non-cicatricial alopecia. It's divided into 4 types: telogen effluvium, anagen effluvium, androgenetic alopecia or familial baldness, alopecia areata. Telogen effluvium, the commonest form of alopecia occurring 3 to 4 months after stressful events. Pathogenesis, premature transformation of hair follicles into telogen phase, resulting in diffuse hair loss. Causes: postpartum, postfebrile, postoperative, chronic nutritional deficiency, anemia, chronic illnesses, drugs as anticoagulants and beta blockers, psychological trauma. Course: hair is shed for 2 to 3 months, and regrowth occurs in 1 year. Anagen effluvium, pathogenesis, selective toxicity to active roots of anagen hairs, leading to loss of hair. Causes: cytotoxic drugs, vitamin A, oral retinoids, and X-rays. Androgenetic alopecia or familial baldness. Pathogenesis: activity of 5-alpha reductase enzyme is accentuated in susceptible follicles. Testosterone is converted to the more potent dihydrotestosterone, decreasing protein synthesis in target follicles, shortening of anagen duration, and increasing in the telogen shedding. Clinical picture: hairs are thinned out. In males, it begins by frontal and bitemporal recession, and then it involves the vertex. In most affected females, hair loss occurs in the vertex with sparing in the frontal hairline. Treatment: surgical hair transplantation, medical, topical minoxidil 2 to 5%, oral inhibitors of 5-alpha reductase, such as finasteride 1 mg per day, oral anti-androgens and estrogens used only in female androgenetic alopecia. Surgical hair transplantation. I think I've already said that. Alopecia areata. Pathogenesis: anagen arrest, early transformation into the telogen, loss of hair from a patch of completely normal skin. Hairs are slightly tapered, forming what's called exclamation mark hair. Etiology: genetic factors, 10 to 20% of cases give positive family history. Immunologic factors proved by perifollicular lymphocyte infiltrates, association with autoimmune diseases as vitiligo, increased incidence in atopic individuals. Emotional or psychological stress may precipitate alopecia areata. Clinical picture: oval or rounded patches of hair loss, suddenly discovered, are the initial presentation of the disease. Types: localized type: one or few patches occur on scalp, beard, or eyebrows. Involved skin is smooth and totally devoid of hair. Ophiasis: hair loss occurs along the scalp margins, usually resistant to therapy. Alopecia totalis: hair loss involves all scalp hair. Alopecia universalis: hair loss involves all body hairs. Course and prognosis: unpredictable with spontaneous remission and exacerbations. Some cases may persist for long periods. Management of alopecia totalis and universalis is unsatisfactory. Treatment: local therapy, corticosteroids, topical or intralesional injections, minoxidil 2 to 5%, topical POVA therapy, local soraline plus ultraviolet A light, irritants as tincture iodine 2 to 4% and anthraline, systemic therapy, systemic POVA, sedatives, antidepressants, corticosteroids in alopecia universalis. Sebaceous gland disorders. Acne vulgaris. Acne is the most common dermatological disorder in adolescents, and it may persist or start in adulthood. Chronic inflammatory disorder of the pilosebaceous unit. Acne or its sequelae can impair patients' quality of life. Primary lesion, comedo. Keratinous impaction within the follicular canal with open orifice, called open comedo or blackhead due to oxidization of debris, or closed orifice, closed comedo or whitehead. Other lesions include mixture of papules, pustules, nodules, and cysts. Etiology or pathogenesis: hyperproliferation and cohesion of keratinocytes, increased sebum production, microbial colonization of the pilosebaceous unit, particularly by Propionibacterium acnes, androgenic stimulation of sebaceous glands, retained keratinocytes, block the follicular opening, leading to dilatation of the lower part of the follicle by entrapped sebum, leading to disruption of follicular epithelium, leading to discharge of follicular content into the dermis, and then the combination of keratin, sebum, and microorganisms, especially the Propionibacterium acnes, leads to inflammation and formation of papules, pustules, and nodulocystic lesions. Clinical picture: acne usually occurs at puberty. It involves areas rich in pilosebaceous unit, face, back, chest, shoulder. Lesions are polymorphic. Primary lesion is the comedo. Other lesions include papules, pustules, nodules, and cysts. Scarring may follow, and it's usually disfiguring. Classification: according to the severity: mild, moderate, severe. Mild comedones with few or no papules. Moderate comedones with papules and pustules. Severe papulopustular lesions, nodules plus or minus cysts. Treatment: topical therapy for mild acne, topical and systemic therapy for moderate, systemic for severe acne. Scar management: topical therapy, antibiotics, erythromycin and clindamycin lotion, retinoids, retinoic acid, and other vitamin A derivatives normalize keratinization, benzoyl peroxide 2.5 to 10% antibacterial effect, azelaic acid 20% antibacterial effect, systemic therapy, antibiotics, tetracyclines, and macrolides with additional anti-inflammatory effect. And then we have retinoids, used for inflammatory and nodulocystic acne, reduce sebum production, normalize keratinization, anti-inflammatory. Side effects include elevation of serum lipids, teratogenicity. Dapsone, used for severe inflammatory lesions and nodulocystic acne. Anti-androgens and OCPs, oral contraceptive pills, used in females with premenstrual exacerbation. Scars management, chemical peeling, and laser resurfacing. And this concludes the dermatology.